Good evening, everyone. Thank you so much for tuning in for today's lecture, which is part of the Women in Surgery Interest Group lecture series. My name is Joelle Shami. I'm the Med2 representative, and today we have the honor of receiving Dr. Samer Doughan as a guest lecturer. Dr. Doughan is a clinical assistant professor of surgery at the American University of Beirut. He had completed his medical studies at AUB before becoming a resident in the Division of General Surgery at AUB also. He then completed his fellowship in gastrointestinal surgery at Watford and Mount Vernon Hospital, and then at East Sussex Hospital, both in the UK. Some of his main clinical interests are inflammatory bowel disease, pelvic floor dysfunction, colorectal cancer, and laparoscopic surgery. Following our previous lecture about perianal disease, today Dr. Doughan will be talking to us about IBD, a topic that I personally, just like many of you I'm sure, am very interested in knowing more about. During this lecture, we would like to kindly ask you to please mute your microphones, and we will be taking questions all throughout in the chat box, so feel free to type any inquiries that you might have. I will now be leaving the floor to Dr. Doughan, and so hope you all enjoy.
Well, good evening, everyone. It's a pleasure again to be here at this special series. I really enjoyed being part of this, especially last time when we had a journey with perianal diseases. And today I'm going to take you through a different journey, a different discussion with you, with a bit of more involvement from the technical aspect, because I needed to sort of show you a few things. But to start with, inflammatory bowel disease is a specialty that epitomizes multidisciplinary approach. So when you want to think about inflammatory bowel disease, this is a disease where everybody should work hand in hand in order to get the patient to the shore of safety. Simply because you really need the support of everyone. You need the support of mainly a gastroenterologist, because he's the first person that will receive the patient, and he will be the person who will continue the care of the patient. You will need the support of your radiologist, because it's very important to get enough information about where the disease is, what are we dealing with. Very important to have the help of your pathologist, because as you might see along this journey, that there are multiple aspects of itis that we need to know what it is. Is it one type or the other or the third type? Because this has a major impact on their prognosis. You need the help of your stoma therapist, because a certain percentage of these patients will end up having a stoma for a period of time, and you need them to have to understand them. And more importantly, you need the support of your previous patients, because these are the people who have been through the journey and who will, in fact, tell your patient what to expect in their upcoming journey. I'm going to take it slowly, and I would ask you to, if you want anything, please stop me, either button or send me something through the chat box so that I can stop. You have to think about, the two types of inflammatory bowel disease, and the two types of inflammatory bowel disease, I call them the cousins. Or in reality, if you have ever dealt with non-identical twins, you will find that one will have ulcerative colitis and the other one will have Crohn's disease. And the difference is simply in the form of the inflammatory process that involves the bowel wall. So one type is an ulcerative with skip lesions. The other one is ulcerative and a continuous lesion. All right. One is, as we say, anus, mouth to anus, which is Crohn's disease. The other one is simply allocated to the colon. So it's very, very important to identify and know which disease we're dealing with, because this will allow us to think about how do we treat them. So if you want to have a look at them, it can affect your mouth and down to the anus. Most of, or a large proportion of your patients will have an inflammatory process around your terminal ileum in the Crohn's disease, and you have a decent proportion who will have perianal disease associated with your inflammatory process. You will have people who have isolated perianal Crohn's disease. This does not happen in ulcerative colitis. In ulcerative colitis, this is a disease that starts in the rectum and that migrate more proximally to become a pancolitis. And that's very important. So do we have any idea about the etiology, sorry, the epidemiology? Usually, we have in the West, we have definitely a higher proportion of Crohn's disease. We're talking about around 8 to 15 people per 100,000. We're not sure why it is lower in places like Asia, Africa, or South America. Definitely, it's more apparent in the northern part of the world. It definitely has a higher incidence in the Ashkenazi Jews, but that we don't know why. We don't know why this epidemiology is there. So if you think about it, usually ulcerative colitis peaks during the third decade, and then usually it goes again, or it appears again in the seventh decade of life. Crohn's disease is definitely lower per incidence than ulcerative colitis, but it as well affects more northern hemisphere population. And again, it has a very similar bimodal distribution, but usually to a younger age group. So how does it present? It presents with recurrent bouts of bloody diarrhea, mucus in stools, some abdominal pain, and a bit of weight loss. But usually it's this change in your bowel habits, as the patient will tell you, I have a looser form of stools that contains blood and mucus. Okay? And it's usually, as we say, and we repeat again, it starts from the rectum, and it goes, as it goes on, it involves more proximal portion of the colon in a continuous fashion. That's very important. So if you see any skip lesions on endoscopy, that is not an ulcerative colitis. Could be most likely Crohn's. So if you look at under the microscope, you will see edema and congestion of the mucosa with infiltration by lymphocytes, plasma cells, and polymorphonuclear granulocytes, cryptapsices, architecture distortion, and ulceration. So how do we define it? Well, we say if it is located to the rectum, it's called proctitis. If it involves the left side, we call it left-sided colitis. And if it involves the whole of the colon, we call it pancolitis. And sometimes if it's so severe, it gives you what we describe as backwash ileitis. You look at the colon, you will see a bit of inflammation, and that's not Crohn's, that's backwash ileitis from severe ulcerative colitis. Now, as we said, Crohn's disease is different. Crohn's disease is a transmural inflammation, skip areas. You will have areas that are normal, areas that are abnormal. And that is why that transmural inflammatory process will lead patients to have this fibrosis or inflammatory strictures. And that's why it leads, because these strictures and fibrosis will allow to give sinuses, microperforations, and fistula formation. So, and we repeat again, it can involve anywhere in the GI tract. So, do we have an etiology? Do we know why do we have patients of having ulcerative colitis or Crohn's disease? A lot of patients walk in the clinic and ask, Why do I get it? Well, it's really a multifactorial cause. You can have a combination of environmental, genetic, and immune causal elements. We cannot pinpoint one cause. Okay. So do we see any sort of consistent observations in IBD patients? Well, definitely geographic regions are very important. Environmental factors are very important, especially as diet and exposure to certain microorganisms. Alcohol, oral contraceptive pills, tobacco use, especially tobacco use in Crohn's disease. Tobacco, for example, it causes exacerbation in Crohn's disease. Well, it has a protective value in ulcerative colitis, and I can never explain it. Okay, is there a genetic relation? Yes, there is, and I've just highlighted to the fact that you can see non-identical twins who each one of them will have a different form of inflammatory process, and I suspect there is some form of a genetic preparation or preparedness to develop inflammatory bowel disease. Just to take you through the journey after this short brief, in reality, if you understand this slide, you really understand most of IBD. So the most important part of our treatment start from the first step. And you have to institute the disease, the diagnosis. That's not initiate, it's institute. So you have to institute the diagnosis. We have to confirm that we are dealing with an inflammatory process, because you can have other forms of colitis that are not inflammatory. You can have infectious forms of colitis, Campylobacter, E. coli, you can have CMV colitis, you can have infectious forms of itis, but we have to confirm that are we dealing with ulcerative colitis or Crohn's disease. So once we institute the diagnosis, then the plan is to initiate the treatment in order to achieve remission. That's the plan. And that's where we all failed in the past of getting patients to be well treated, because we never led them to achieve remission. So the treatment is a little bit of hit and miss. They take a bit of simple medications here and there, but we don't have a treatment by the sledgehammer to make sure that remission is achieved. And then once we have achieved remission, then it's our job to maintain them in remission. And as you have realized through all this discussion, the surgical team is not involved in this. Well, in most of the parts of the world, and colorectal surgeons do perform their own, and I used to do my own endoscopies, but it's our part and parcel of work of instituting the diagnosis. And how do we institute the diagnosis? Well, the best, and you all know, the best evaluation is an ileocolonoscopy or a colonoscopy, where you go through to reach the terminal ileum, and you take biopsies from the affected areas, and you take generous amount of biopsies that you have to send to the lab. And that we go back why we need the pathologist, because the pathologist would have to look at these biopsies of yours and assess them and decipher them in order to tell us, is this a form of a transmural inflammation that will suggest the presence of Crohn's, or is it simple ulceration suggestive of ulcerative colitis? Do we see granulomas? Yes or no? This is very important. And then, as we say, when we say initiate the treatment in order to achieve remission, that means we're talking medical treatment. And I'm not really going to bore you with the medical treatment, but most importantly, it's again a form of a ladder treatment, where you start with the simple material that can alter, that are inflammatory process modulation. So the simple stuff you need to think of are, the cousins of the aspirins, the salicylates, whether we start with topical or whether we start with oral, and whether the oral that you give is absorbed in the proximal small bowel or in the distal small bowel in order to achieve better control of the colon. That is all depends on, as we suggested from the beginning, a multidisciplinary approach with your gastrointestinal, your gastroenterology colleagues. Okay, and we usually try as much as possible to start with the simple medications before we jump on to the more aggressive medications. Remember the proctitis or the distal disease in ulcerative colitis can be treated with simple topical therapy, such as salicylates, corticosteroid suppositories, or corticosteroid enemas. The distal disease really does not need systemic therapy. It's more the more florid disease, whether it is pancolitis or severe left-sided colitis, where you need to think of systemic therapy. In terms of Crohn's disease, it is the same. The same applies. However, now we factor in a lot of other issues. Are the patients younger? And if they are younger, that means they are at higher risk. And then the higher risk they are, the more you need to hammer the disease in a different fashion. So you have to think it's all of them. All the medical treatment is a form of modulating your inflammatory response and try to reduce your inflammatory response. So as you see, the medical treatment is constituted of salicylates, corticosteroids, immunomodulators. Usually the most commonly used is azathioprine. Then the other options available are either 6-mercaptopurine, cyclosporin, methotrexate, and now you have a huge array of biologic agents that you use. The most common is infliximab. Then the next one is, I know them by they're not by the generic name, but they're by their trade names, so Humira, Entyvio, or Stelara, which are the newest form of biologic agents. When I did my fellowship in colorectal surgery, infliximab was just started on its trial. Now we have a huge amount of trials on all the other biologic agents. I'm going to stop for a while. I'm going to stop sharing and then ask if we have any questions before we move on to the surgical treatment. So if I want you to take anything from the first 12 slides that I have presented, well, it's very simple. What I'm trying to tell you is the following. It's a multidisciplinary approach. Most of these patients should be discussed with all the available information. And then the real plan is to look at how can I, once I have instituted the diagnosis, what is the best form of treatment to achieve remission, and then what is the available options to maintain that remission. Definitely there should be a lot of work on, there are certain environmental factors. Smoking in Crohn's disease is a no-no. I see a lot of patients here where they keep on hammering them with biological agents, but yet they continue to smoke. So you have to do all these alterations before we continue to treat. So anyone has any idea where does surgical treatment fit in? Okay, Mjad Hasari will say where medication, it's refractory, absolutely. So surgery becomes the option of care when the medical team comes to you and say, we have no further available options to treat that patient. Okay, so let me have a look. So if you have no other options in terms of treatment, so the gastroenterologist has thrown the white towel and says, I can't treat that patient. So you have to think how to move on. The other option is whether or not you have a patient who has strictures and has some form of bowel obstruction. Definitely, there are a couple of people who have mentioned the risk of, malignancy or neoplasia. Well, you have to park malignancy for a while, because if you think about it, the risk of malignancy only starts after around 20 years of the disease. After 20 years, your risk of malignancy in ulcerative colitis is around 10% more than the regular population, but then it increases by 1% every year. So then at 30, 35 years, you're at 25% above the general population, which is at 5%, and that is essentially your risk increases. Now, there are other issues that you have to think of. Do I have complications from the treatment? Is the patient managing to deal with all these biologics? Some of these biologics will give you some malignant skin changes. So it's very important to think about this way. Am I getting complications? And somebody mentioned it. The complications of the disease. Do I'm getting too many fistulas? Am I getting small bowel obstruction? Am I getting fistulas into organs that I don't really like? Does the patient have, for example, an iliovesical fistula or an iliocutaneous fistula? All right. Someone mentions, do I have severe symptoms that regress with surgery? Usually, you're treating not symptoms and signs. You're treating the disease that is being slightly aggressive, and you're unable to control through it. So in ulcerative colitis, you have to think about it. It's either an operation that is really emergency. So you have a patient that was admitted to the hospital by the medical team, thinking that they can treat their colitis. Their colitis is getting worse, which means they are seeing regular deterioration of their number of bowel habits. Their proteins, albumin and globulin are getting worse by the day. They're getting more symptoms, and they are losing more blood and becoming anemic. And then, despite every form of treatment they have tried to deal with that, what we describe as your toxic colitis or fulminant colitis, you're unable to treat it, then you have to consider an emergency operation. Now, elective operation is an operation where the patient has been on treatment, but the treatment has become refractory, that the gastroenterologists have thrown everything, that we say they've thrown the kitchen sink at the patient, but nothing has improved. So this is where you have to consider what we should do with the patient. So as we say, a lot of the times we see patients with fulminant colitis admitted on the ward, where they have, IV hydration, bowel rest, antibiotics, corticosteroids. It doesn't work. They give them even more. They try them on 6-mercaptopurine. They try them on all the other forms of immunosuppressants, including the biologics, to no avail. And so what is the gold in ulcerative colitis? The gold standard of treatment is very simple. If you have a patient who has ulcerative colitis or fulminant colitis, you need to essentially sacrifice most of the colon. So we perform a procedure called a total colectomy with an end ileostomy. Now, there is a huge discussion about whether or not your rectal stump is produced to the outside, and I'll show you in the picture and left as a mucus fistula or not. But the most important thing, that's the first procedure you do. A total colectomy with an end ileostomy and a mucus fistula. Now, then you come back after the patient has gained some health to resect the end of the rectum. And then you have to have a choice and a discussion with the patient. If the patient doesn't mind a permanent ileostomy and they're happy to have a permanent ileostomy because they don't want to go through major surgeries, then you just do a completion proctectomy and they live with an end ileostomy. If the patient wants to have a bowel continuity, then you perform on them what we describe a J pouch. So you resect the rectum, you reconstruct the ileum into a pouch, and you use that and you attach that pouch to the anus. So if you look at the picture one, and you see the colon in green, that is the colon you resect, and that when you produce, as in picture two, the terminal ileum as an end stoma, and that's the rectum, which is stapled. But in reality, I usually get this rectum attached to the skin, so that just in case you have some element of inflammatory process, it is produced to the outside. And then in picture number three, it shows you the reconstructive procedure where you do the pouch. So you form the end of the terminal ileum, a pouch of 18 to 20 centimeters that can accumulate between 250 and 300 cc of water, and you suture it to the anus, or you staple it to the anus. You always cover this operation with a loop ileostomy that you close after 6 to 8 weeks. All right, I'll stop again and see if anyone has any question around the surgery for ulcerative colitis. So is everything clear regarding what surgery do you provide to ulcerative colitis? Now, even in elective setup, you do exactly the same operation, because we know now from a lot of our studies that what we describe as a 3-stage procedure is much more safer and with better outcome when you do this 3-stage procedure. I want to take you through what we do to Crohn's. While Crohn's is a different procedure, is a completely different procedure, because in Crohn's, there is no one technique that you can do. You have to think about where is the affected disease and what should I resect. So you might have either an isolated resection of small bowel or an isolated resection of the terminal ileum, and because you have to resect the terminal ileum, you have to resect the cecum because of the blood supply. Then you perform an ileocecal resection, or you do a form of a partial colectomy if you have an affected part of colon that you need to resect. So, as I say, this is completely fundamentally different from ulcerative colitis, and you usually have to attack the specimen where the disease is. Now, you have to remember that Crohn's disease is very prone to recurrence, and that's why before we treat the patient, we identify in the multidisciplinary meeting which patient is high risk, and these patients, we challenge them with medications the minute we finish surgery, because we worry that they might have quite a bad relapse. And when you lose so much bowel with repeated bowel surgery, then you have to start thinking about how do I deal with the stricture, or if I have to deal with it, then the problem is, because you want to save, you perform what we call a stricturoplasty, which is something I'm going to show you in a second. But the most important thing is, remember that Crohn's disease, it is not like a one standard procedure like ulcerative colitis. You tackle the segment where it is affecting your disease. Now, opening a parenthesis about this and talking about perianal Crohn's disease, you have to think that the treatment of perianal Crohn's disease is definitely and mostly related to the basic disease. So when you have someone who's diagnosed to have perianal Crohn's disease after having a recurrent anterior fissure, the treatment is not surgery to the fissure. The treatment is you optimize their medical treatment in the hope that this fissure will heal. So whenever you have someone who has quite an unnerving perianal disease, or something that you have not seen so far, then always think, am I dealing here with Crohn's? And if this is Crohn's, how I can deal with it in a better way, rather than exposing the patient to multiple operations. Because keep in mind, Crohn's disease and surgery in the anus, they don't heal very well. Okay, so that's what I was talking about in terms of structuroplasty and the presence of strictures. So when you have someone who has multiple operations, then you have to think, how do I perform and how do I keep the length of bowel as safe as possible? Because you're worried that with repeated resection, you're going to end up with short bowel syndrome. And that's why sometimes we refrain from resections but perform structuroplasty. If we are going to resect in Crohn's disease, confirming that the patient nutritional status is okay and that they are not immunosuppressed, then you can do a primary anastomosis. However, if the patient is medically unstable, nutritionally depleted, on large dose of immunosuppressant, then you really cannot do any diagnosis and you have to consider temporary stomas. That is the pictures of that we teach our residents of how you do perform a structuroplasty. So you identify the structuroplasty. If it is far longer than 15 centimeters, then you cannot perform that procedure. You have to do a resection. But if you have a short stricture, then you can do a structuroplasty where you incise the bowel longitudinally and then you close it vertically, or you essentially do it like the hynecamiculates, which is on the right side, where you essentially tent the bowels and do a side-to-side anastomosis. So if I have to re-summarize the second part of the talk, which is where do the surgeons fit in these kind of operations, then it's very clear. We only interfere when the case is discussed at the multidisciplinary meeting and we know that the patient has failed medical treatment or has had complications from the disease where further treatment will not resolve it, or when we think the patient's having a certain impact on their welfare, they're losing weight, they're having anemia, then we interfere. In ulcerative colitis, whether it's emergency or elective, we perform mostly one kind of surgery, which is a three-stage procedure called a subtotal colectomy with an endodostomy. Come back to do a completion proctectomy and do an ileoanal J pouch reconstruction, and then the third step is to close your ileostomy. Once you have finished the treatment, usually ulcerative colitis patients do not need any further treatment, and all what they need to do is a regular follow-up for their J pouch, either by the surgeons or by the gastroenterologist. And a complete contrast is Crohn's disease, because when Crohn's disease, you need the surgery, you're tackling the specimen or the area that is affected that is causing the symptoms. And because you tackle it this way, then you have to consider what form of resection, and you have to be very limited in your resection. Generous resections in Crohn's are usually not advised because you essentially are exposing more or less the patient to have short bowel syndrome. You have to try as much as possible to save the bowels. And then you need to decide, is the patient well enough to have an anastomosis, or shall I do a temporary stoma for a period of time? Now, dealing with patients coming back to the operating room for further treatment or for further resections, then you have to think, can I do some structuroplasty that will essentially save us few length of bowels, because these patients will become desperate to keep as much bowels as possible. Of important note are the perianal Crohn's disease, and that's very close to the discussion we had a couple of days ago. A patient who has any suggestion of perianal Crohn's disease could have to trip to the operating room, a decent biopsy is taken to confirm and institute the diagnosis, and then treat. Please do not operate on patients where you think they have perianal Crohn's disease, because you essentially put yourself in a quagmire of complications of no wound healing. So be very careful. And if you have any concern, then pick up the phone, call your colorectal colleague and say, I have this 20-year-old and I'm not happy with her fissure. Or I have this 25-year-old who I'm not happy with the shape of their anus. Don't be too courageous, especially in peri and Crohn's disease, because if you step on the wrong foot, you will continue on the wrong path. Now I'll stop and I'll take some questions. So is it better to start with the colostomy first, then the colectomy, or the inverse? And Jad, are we talking about treatment of ulcerative colitis or treatment of Crohn's disease? Because simply in Crohn's disease, there is a small role of a proximal defunctioning, but we don't really advocate it. Now, always in ulcerative colitis, you start exactly again. A subtotal colectomy, whether open or laparoscopic, to essentially resect most of the colon, leave a rectal stump and a portion of the rectosigmoid, and then get out, produce an end ileostomy. And then if you really want to have a mucus fistulae, so no, that's not important. So first is the colectomy. Then you do you perform a reconstruction procedure. So always get rid of that disease, otherwise your patient doesn't get well. Now you've asked as well whether John Paul has asked whether a preference for open versus laparoscopic colectomy. In all honesty, most of the studies confirm there is really no major difference. However, there is enough evidence that if your laparoscopic procedure, especially in people who have bad colitis, so fulminant colitis, and you take them to the operating room to do laparoscopic surgery. Now, if you're a skilled laparoscopic surgeon, a subtotal colectomy should take you in an average UC guy between 2 hours and 3 hours. If you can perform that in 2 to 3 hours, then you're fine. But if you're trying to do laparoscopic surgery on patients who already are on the back foot because of their disease, then please do not perform laparoscopic surgery. Just accept that you have to take it and do it by open surgery, because if you know how to do it well and quickly and swiftly, your patients will have a better post-operative outcome. Sausan is fairly right. Laparoscopic will give you less adhesions, less chances of small bowel obstruction. So most of the pouches that we have performed here, and we have the highest number of pouches in Lebanon since 5 years. Most of the pouches have been performed by laparoscopic technique and not open surgery. Even the people who have had an open subtotal colectomy, we try to give them a laparoscopic reconstruction. The people who we have done them only open, and there are, I think, 1 or 2, are done because they have had complications post their surgery. So it is not easy to approach their pelvis. But in reality, yes, most of them are approached laparoscopically. Well, I think that's I call it a day then, because unless someone has any question that is not getting to target as quickly as I think.
Hi, Doctor.
Hi.
It's Adam Makaram. I have a quick question, but not related to the surgical aspect of IBD.
Okay.
We've been taught that there are like many extra manifestations, like primary sclerosing cholangitis, uveitis, and other manifestations. But the patients I saw on the floors having IBD, like I didn't see these manifestations. Like my question is, to what extent and what percentage of the patients have these manifestations?
That's a very good question, Adham, and thank you for. I think you've mentioned it in the question, but I think I oversaw it. With the presence of extraintestinal manifestations are very important, because usually they indicate a form of worse disease. So someone who has ulcerative colitis and has primary sclerosing cholangitis, usually when they present with a worse form of colitis. you have to keep in mind when you're treating them is you're treating them more aggressively. And the same apply to skin manifestations. We used to have a patient who every time her colitis worsened, her skin manifestations worsened. And every time her skin manifestations caused her problems, we thought that her colitis was getting worse. In reality, the reason why we got rid of her colon at the end is because when we got rid of her colon, most of the skin manifestations disappeared. So you don't see them a lot. I think they are part between 5 to 8% of your colitis. You don't see them much, but when you see them, they are more or less a heralding sign that the patient has more aggressive disease than your regular patient. So are there any post-operative dietary changes for patients who have had total colectomy? Very good questions. Yeah, most of the patients who have had a pouch surgery, then they have to advise them to eat slightly more carbohydrate-based diet. They need to have more starchy stuff so that they absorb more water, so that they don't get to the toilet more often. You have to keep in mind these patients, when they have pouch, they're not expected to go to the toilet like the 2 to 3 times. They will go between, usually the expected number, 6 times during the day, once or twice during night. If we achieve them to go to 4 times and be dry at night, that will be a great success. So we try as much as possible to give them, to ask them to eat more starchy stuff, reduce the amount of lots of drinks, reduce the amount of fruits and fibers, and at the same time to try some either metaclopramide, try some Imodium, and try slightly more sodium phosphate. You're mostly welcome. As I said last time, if you need any advice or any info, you have my I think Rasha has spread my email, so you can send me any email for any further questions. And if any one of you who are not from AUB or from the region and who wants to come and watch any of these cases, let me know.
Thanking everybody for attending this lecture. And I was saying that we would love to have everybody's feedback. So if they could please fill out the 8 poll questions that we have written, it would be amazing.
Okay, perfect.
Thank you so much.
Can you please let me know the outcome?
Yes, for sure, for sure.
All right. Take care, everyone. Be safe, stay safe.
Thank you.